So our first research paper will be presented by Dr. Longhai Jin. Dr. Jin is a vascular registrar at Canberra Hospital and has a keen interest in management of diabetic foot disease and optimising its outcome. Diabetic foot disease tends to be a chronic recurrent issue and imposes significant burden on the patients as well as our healthcare system. So as per the first session, we'll take 2 questions at the end. So everyone, please welcome Longhai.
Thank you, Laura. Thank you, Laura. So my name is Longhai, one of the vascular registrars at the Canberra Hospital. And good morning, everyone. So this morning, I'll be talking about the clinical utility of proximal bone chips in the treatment of diabetic foot infections. So diabetes is a highly prevalent chronic disease. It affects 1 in 10 people worldwide. But even more alarmingly, diabetes-related mortalities have increased by 70% in the last 2 decades. Diabetic foot ulcers have a lifetime risk of 34%, and it has an annoyingly high recurrence rate as well. 60% of diabetic foot ulcers will develop into infections, and osteomyelitis will complicate up to 20% of moderate infections and up to 60% of severe infections. So every year in Australia, 10,000 hospital admissions, there'll be 10,000 hospital admissions for diabetic foot disease, and 4,000 to 6,000 amputations will be performed. And the 5-year mortality for diabetic foot disease is fairly poor as well. So diabetic foot infections and osteomyelitis can be diagnosed based on a combination of clinical assessment, biochemistry, and X-ray plain films. In some cases where the initial assessment is equivocal, advanced imaging such as MRI might be indicated. So once the diagnosis is established, surgical resection of the infected bone is regarded as the gold standard, and antibiotics will be required as well. So the current guidelines from the International Working Group of Diabetic Foot Disease recommends sending proximal bone chips during resection operations for microbiology as well as histopathology. If the bone chips come back as positive, then the patient should be treated for residual osteomyelitis, in a way that's fairly similar to positive resection margins in oncological operations. So our study aimed to evaluate the utility of proximal bone chips in the treatment of diabetic foot infections, and also to evaluate the congruence between bone chip microbiology as well as histopathology. So we conducted a prospective study from June to December last year at the Canberra Hospital. Patients undergoing transphalangeal and transmetatarsal amputations for diabetic foot infections and osteomyelitis were recruited in the study. The surgeon decided on the amputation level based on preoperative clinical and radiological assessment, as well as the intraoperative appearance of the bone. So once the amputation has been performed, the operator would then collect a proximal bone chip specimen using sterile instruments, and that will be sent for microbiology and histopathology processing. So during the study period, we were able to gather 120 patients with a male proportion of 78% and a mean age of 70 years. And as expected, these patients had the fairly common comorbidities such as peripheral arterial disease, diabetes, smoking, ischemic heart disease, and metabolic syndrome related disorders. About 3 in 4 patients had their diagnosis made either on clinical assessment or X-ray imaging. And 52 patients required transphalangeal amputations, and 68 patients required transmetatarsal amputations. 17 patients actually had multiple digits amputated in the same operation. So in terms of the proximal bone chip results, 77 out of the 120 patients had positive microbiology. And it was interesting to see that majority of these patients actually had discordant negative histopathology. For those with positive microbiology and positive histopathology, 8 out of the 10 patients required revision amputations at a very early stage. Nevertheless, for those with positive microbiology and negative histopathology, there was still a small proportion of patients who required revision amputations at a later stage. In the patients who had negative microbiology, it was also interesting to see that no one had positive histopathology. And all the patients with negative microbiology were successfully treated with short-term antibiotics, and no one required revision amputations by 3 months. So we looked into the group of positive microbiology and negative histopathology a bit more to see if there were any other risk factors that could have predisposed them to having a revision amputation. And we saw that these patients, so in the revision amputation group, the proportion of their comorbidities were higher compared to the no revision amputation group. But due to the size of our study, we were not able to establish a statistical significant p-value. So the learning points from our studies are, so current guidelines recommend using or sending proximal bone chips to assess for residual osteomyelitis. But in current times, this is only practiced at the surgeon's discretion. Bone chip microbiology tends to overdiagnose residual osteomyelitis, and this is probably from the contamination from the surrounding soft tissue infections. In the small proportion of patients who had positive histopathology, it was the predictive value for the histopathology for revision amputations at an early stage was very high at 80%. But histopathology processing can often take weeks. So the current practice for antibiotic regimen is decided based on clinical assessment and bone chip microbiology. So in the future, we can look at ways of improving histopathology processing to optimize its clinical utility in practice. And yeah, so that concludes my talk. So thank you for the opportunity this morning.
Thank you very much, Longhai. Very interesting talk. I guess it correlates a little bit in ENT when we have skull-based osteomyelitis secondary to otitis externa in these diabetic patients, and infectious diseases will often ask us for microbiological samples from bone chips, which is always a hot, contentious debate as to whether we operate unnecessarily on these patients to provide microbiological samples. So very interesting. I believe there is a question in the chat group for you. What percentage of these patients were on antibiotics before the surgery, and did this affect outcome?
Yeah, so in terms of the percentage of patients with antibiotics, so I think majority of these patients were on antibiotics because they require hospital admissions. But in terms of affecting the outcome, I think it's not as a strong indicator for the outcome, but I am also looking at the statistics for that as well to see in terms of how the usage of preoperative and also rationalizing post-operative antibiotics and how that can affect the outcome.
So there's one other question for you. Can you clarify what proportion of patients with positive micro required amputation, and what proportion with negative micro required further amputation? So I think it was just that original slide.
Yeah, so going back. So in terms of so negative micro, so no one required amputation by 3 months. And in terms of the positive micro, so overall, so about 20% required revision amputations at 3 months. But if they had positive histopathology, then the chances of them requiring earlier amputations are a lot higher. So the positive histopathology has much higher predictive value.
Yeah, and I think that the follow-on question from that is, does this suggest that there is inadequate amputation initially? I guess, was the bone chips taken from the residual stump left in situ or from the resected specimen?
So the bone strips are taken from the residual stump left inside you. And yeah.
I guess the question there is, does that indicate that the initial resection should have been more extensive, in your opinion?
So I think, yeah, that's an excellent question. And so we often make these based on clinical and X-ray assessment and also intraoperative appearance of the bone. So I think if we were a bit more aggressive, then people would lose a lot more tissue than sometimes what is actually necessary. And I mean, ideally, so further imaging such as MRI scans would always be ideal to provide that extra step of clinical information. But I think due to the limitations of accessibility, that is not always available. Yeah.
Yeah, and that a lot of questions coming in through. That follows on into the next question, that what is that role of imaging in determining preoperative the level of amputation? I guess you suggested there that MRI is helpful, but not always necessarily possible. All right, any further questions for Longhai? No, it looks like that's it. So thank you very much for your presentation.
Okay, thank you everyone for the opportunity.
Thank you.